Sound check, sound check. Hi, folks. Professor Gulliford here. I am recording for you the Chapter 5 material, which we did not get to in class earlier. And I would just like to be sure to cover everything you need, especially with a quiz coming up. And pay attention to that review sheet or study guide which I sent. If you really focus on those things, you will do well, both on your boards and on the tests in this course. So it's the thorax. That's the chest, the bones, muscles, movement, intercostal muscles. Those are between the ribs. The diaphragm, which should be dome-shaped and should drop each time the patient breathes in. Abdominal muscles, which are used mostly to exhale. Accessory muscles, and then abnormal conditions that affect the muscles of ventilation. I'm thinking about a kid right now who has spinal muscular atrophy and has to have their head in just a particular position. Otherwise, their airway is blocked off. What a way to live. And thankfully, there is a great pediatric rehab facility where that young one can live and have parents close at hand for support and very good caregivers. It's a philanthropic venture in Oklahoma City. So at any rate, there are all kinds of muscles that are involved in breathing, and not just the diaphragm. The diaphragm is important, but not just the diaphragm. Movements, movement of air in and out of the lungs, and it's all done by muscles. The diaphragm is the most important muscle. Inspiration is active, but exhalation is passive, meaning it just happens. There's no effort expended, unless you're blowing out the candles on your birthday cake. Then there is some effort expended because you're blowing harder than usual, or if you're doing a pulmonary function test. But normally it's a passive process. Skeletal structure, the bones, the spine, the ribs, the sternum, and they enclose the heart, lungs, esophagus, nerves, and blood vessels. There are 33 vertebrae, 7, 12, 5, 5, and 4. I still have that memorized from the cervical, 7, thoracic, 12, 5 lumbar, 5 sacral, and 5 coccyx vertebrae. Those last few are very, very small, but nonetheless, 33 total vertebrae, 12 thoracic. And, there are a couple of ribs that are not attached on both ends. They're called floating ribs. Just the 11th and 12th are those ribs. Skeletal structure, the first 7 ribs we call vertebrosternal ribs. They're true ribs. They attach both to the vertebral column and to the sternum. However, the other 5 ribs are called false ribs, and the last 2 are floating. They do not articulate. So I think they're more prone to injury and fracture because of that. I've certainly seen a lot of those fractures over the years. So here's what the thoracic cavity looks like. We've got the manubrium, that's the top of the sternum, the body, and the xiphoid process. It's all together considered the sternum. There's a jugular notch at the top, the clavicle. I don't know if you've ever broken your collarbones. I did growing up, and it hurts. But the clavicles and the angle of Lewis, that's where the manubrium becomes the body. You will sometimes hear that referred to on X-ray. So there you go. That's a good look at the thoracic cavity. The sternum has 3 parts: the manubrium, the body, and the xiphoid. I did not say gladiolus because I've never once heard that used on a test or at the hospital. It's just going to be manubrium, body, and xiphoid. Sternum is about 17 centimeters in length. When you do chest compressions, you're compressing the lower half of the sternum, and you definitely will be doing that in your clinicals. Sternal fractures can be very painful, but usually the patient recovers quickly, 8 to 12 weeks, and they have recovered. We also don't see as many sternal injuries because of airbags. Airbags have made a very important difference. First came the seat belts, then the lap belts, or what are they called? Chest restraints, I guess, and then the airbags. Sometimes we see a pigeon breast. That's where the sternum is sticking out in front further than it should. Or sometimes a funnel chest, also known as pectus excavatum. That's where the sternum is caved in to a certain extent, making a valley. Let's see here. The xiphoid process is the little cartilage tip on the end of the sternum, and that is a important landmark for CPR. If you haven't had your CPR, you certainly will soon before you head off to clinicals. So there we go. Vertebral column, 24 vertebrae, cervical, thoracic, lumbar, sacrum, coccyx, as we mentioned here a minute ago. And that's a really good picture of them. You know, there normally should be a curve. It's not an exaggerated curve, and it's not a side-to-side curve. It's front to back. And that's how the weight is balanced to, best support the patient. Cervical, C. And the C1 is the atlas, C2, the axis. You hardly ever hear those terms at the hospital. I just don't think you're going to encounter that at all. Okay. Well, thoracic vertebrae. Oh, you know what? I've kept you guys posted on my exam takers. I had one pass at the high cut score yesterday. So we are celebrating that success. I'll be celebrating with you as you pass your boards also. Thoracic 1 through 12. That's T. Points at which the ribs connect to the vertebrae are called the costovertebral joints. Those joints bring about a lot of trouble, I must say. We wind up with pinching of nerves there and compression of the disc between the vertebrae. So there we go. Lumbar spine, L. Those are the L vertebrae, and 1 through 5. Those have a lot of weight-bearing responsibility, and consequently, they're prone to back problems. I say most of our patients who present with back problems would say it's lower, as in lumbar. Here's the pelvic girdle. My wife, Terry, fractured her tailbone at one point, just slipped on the ice. And as I look at that structure, I can just imagine how much that hurt. Bless her heart. She's now fully recovered, but that was a bad deal. The bones of the pelvis come together. They're the ischium, ilium, and pubis. RTs don't have very much to do with that, just to be honest with you. Nothing on boards. The tiny piece at the end, the coccyx or tailbone. Coccyx. Just going to pronounce that one more time for you. So, and there are 6 intervertebral discs in the cervical region. I have a friend in the anesthesia profession who unfortunately injured his neck, and it is just an ongoing struggle with the nerves that are pinched in that area. Inside each disc is a nucleus pulposus. It's a jelly-like substance. As the spine moves, it what should we say, cushions. It cushions. And unfortunately, as we get older, it doesn't cushion as well as it used to. And if there's a bad injury, that can also impact how well it cushions. There's normally an S-shaped curve. So don't expect the spine to be straight up and down. It's just not. But there is not a lateral curve, and that's scoliosis. If we have that, it is called scoliosis, which can take on a C or an S shape. And kyphosis is the forward curve. We see this in a lot of elderly women. Conditions and abnormalities, well, there's scoliosis, and it does usually happen in women. So that's why they're showing a female patient here. Conditions, abnormalities of the thoracic skeleton, well, rib fractures are very common. They heal relatively quickly, but they're painful. Nature wanted your ribs to hurt. That's where that old expression of poking the ribs, because it hurts. Nature wanted you to be aware of protecting your chest and everything that's in it. A flail chest, you got to know this for boards, is 2 or more adjacent ribs broken in at least 2 or more places. And what that does is it destabilizes the section of the chest and allows it to flail or collapse as the patient breathes in. That results in what's called paradoxical movement of the chest. So flail chest, two or more adjacent ribs broken in two or more places. For sure, you need to know that. You also need to know that PEEP, positive end expiratory pressure, PEEP, is a very common strategy that RTs use to to treat flail chest. Yeah. Pulmonary contusion is nothing more than a bruising of the lung, about 48 hours for that to stop. Here are the diaphragms, the muscles of breathing. And of course, at the top is the diaphragm. But look at all the others that can be involved: intercostal, transversus, scalene, pectoralis, that's the pecs in your chest, trapezius, sternocleidomastoid. So there we go. And there's a picture of all those muscles. Now, during quiet breathing, if the patient is well, quiet breathing, you don't use those accessory muscles. But during exertion or when there's distress, as in shortness of breath, asthma attack would be an example, then you do kick in those accessory muscles to help. The diaphragm is the big one, the dome-shaped muscle that forms the floor of the thorax. And it drops during inspiration to create a vacuum and allow air to enter the chest. Oh, typically the right hemidiaphragm is innervated a bit higher, and it is located a bit higher because the liver is on that side. The liver is a larger solid organ, and it makes the diaphragm higher on that side. Okay, internal intercostals. These are used in exhalation, and external intercostals are used in inspiration. I wish that was backward. It would be easier for you, but it's not. Intercostal muscles are used to exhale. That's the internal, and external intercostals are used to inhale. Yeah. So it's backward, you might say. Transverse thoracic, that's another group of muscles that can be used not in quiet breathing, but in distress or in severe exertion. Scalenes, sternocleidomastoid, that's the big strap muscle on either side of the neck. And you'll see many of our COPD patients breathing with those strap muscles in their neck. Pectoralis major, trapezius, all these muscles can be involved in breathing, but they're not normally involved in breathing. We have two actions here. It's what's called the pump handle and the bucket handle, and both of those are important in getting air into the chest. Your ribs are moving in both of those directions as a pump handle and as a bucket handle, and the two together create a coordinated breathing effort. Abdominal muscles are mostly accessory muscles of exhalation. When we ask you to blow out the candles on the birthday cake or to do a PFT test, you really kick in the muscles of the abdomen, but otherwise they're pretty quiet. Got external obliques and internal obliques. I was a competitive weightlifter for a while, and we were always trying to improve these abdominal muscles, not to help with breathing, but to be stronger, support the back. If your belly muscles are strong, you're much less likely to injure your back. Rectus abdominis, that's the straight down the middle. Rectus means straight, so right down the middle. That is where the rectus abdominals. Oh, if someone tries to get the six-pack abs that everybody considers attractive, that's the rectus abdominis muscles. External abdominal oblique muscles, those are the ones that kind of move sideways at an angle, I would say. And internal obliques are also there. Pretty much these are muscles of breathing out, and not just breathing out casually, of forcing air out, During normal quiet breathing, the diaphragm moves about 1 to 2.5 centimeters. But if we ask the patient to take a deep breath, they can often go about up to 9 centimeters. So, all right. During passive exhalation, the thoracic muscles relax, the diaphragm returns to its dome-like shape, and that's it. The rest of it is passive. But during active exhalation, where we're asking the patient to blow out, then we will kick in those internal intercostals, and we will kick in the abdominal muscles. Really don't see a lot on boards about accessory muscles, except that if the patient's using them, it should make you think of distress. They are in distress. Diaphragmatic hernia is where you have an opening in the diaphragm. Unfortunately, some kids are born with their intestines in their chest. So I remember thinking as a student, well, I guess that can't be too bad because we would just pull the intestines down out of the chest. But here's the problem. The whole time that those intestines were in the chest, the lung could not develop. So the lung is in catch-up mode and cannot completely catch up ever. And that is, a sad deal. I would have to say that a significant number of congenital diaphragmatic hernias, that's where the intestines are in the chest, patients don't survive. Hiatal hernia is a very aggravating condition where a part of the stomach pushes up through the diaphragm, just even a small portion. And what happens there is that the acid reflux is terrible. Prilosec, oh, what a help it has been. So many clients now can tolerate their hiatal hernia better because of that. Paralysis of the diaphragm can help them for a lot of different reasons, some of those traumatic and some of those disease processes like Lou Gehrig's disease, Guillain-Barré, myasthenia gravis, just to name a few. We have a whole course on diseases where we'll go into much more detail on that. Work of breathing is how much effort does it take for the patient to breathe. Something we're concerned about is if the work of breathing is too high, the patient may wear out. Their respiratory distress may take over, and they're not able to continue breathing. So we must breathe for them. The way we do that first is non-invasively with a BiPAP or non-invasive ventilation. And then we may move on to an endotracheal tube and a ventilator. Here are the retractions. Retractions say distress. When the tissue is pulling in, be it between the ribs or above the sternum, or below the sternum, or above the clavicle, any of those areas where you see the tissue being pulled in, that is retraction, and it means distress. So this is a important chapter. How do we get air in and out of the lungs? Well, the muscles and the bones of the thorax have to do their part. Skeletal structure we talked about in detail. Alterations like kyphosis or scoliosis, you very well may see some of that on your boards. Injuries can result in deeper problems. That whole rib cage was designed to protect the heart and lungs because the heart and lungs are so important. Muscles of the thoracic cavity, the diaphragm is the principal muscle of breathing. Inspiration, active. Exhalation or expiration, passive. And work of breathing, we just talked about. Several conditions can affect the function of these muscles. I'm just going to name the ones that are most common here. ALS, that's amyotrophic lateral sclerosis, Lou Gehrig's disease. Multiple sclerosis, muscular dystrophy, neuropathic disease, that's where you've got an actual damage to a nerve, thyroid and autoimmune diseases, and Guillain-Barré. They should have mentioned myasthenia gravis here also. That's it. So again, my apology, we didn't get to cover that in class, but at least you've got it now that you can watch at your convenience. And I'll turn this into a Zoom video and just put it in the course where you can find it. I love working with you guys. I just graded your case studies that are so good. Oh my gosh, you're on the way, and I'm on the way to a very successful course.